I want to start thanking IRIDEX for inviting me to participate in this presentation and give me the opportunity to share with you this afternoon discussing about this novel treatment strategy for various macular disease, from which we'll be focusing on diabetic macular edema. And we choose diabetic macular edema because, as we all know, diabetic retinopathy and diabetic macular edema are worldwide problems that represents one of the leading causes of blindness and low vision, and then that is also significant across various ethnic groups. Particularly, diabetic macular edema affects up to 30% of the long-term diabetic patient and is also the leading cause of diminishing visual acuity. The history of diabetic macular edema treatment is a 30-year story of intelligence and innovation that starts with the traditional thermic laser results of the ETDRS study, that then evolves to try surgical approaches, and soon after changes again to the pharmacological era, first with the use of steroids, and later on with the reign of anti-VEGF treatments. And finally, the evolution and refinement of technology that led us to the development of MicroPulse laser treatment, from which we'll be talking about. The recognition of VEGF as one of the key molecules in the pathogenesis of diabetic macular edema and the development of the anti-VEGF agents has led to the expert retinal community to choose anti-VEGF agents as the first treatment option in diabetic macular edema with foveal involvement. And this trend is either in US and international. This American Society of Retina Specialists Preference Trends survey result is based on the strong evidence that many well-controlled clinical trials have taught us about the efficacy of blocking VEGF in diabetic macular edema. But when we look to some details in the results of these studies, we can clearly see that the mean visual gain across all of them, either at 12 or 24 months, are linked to a high number of injections needed to reach this visual benefit. With a mean higher number of 9 injections in the first year, if we exclude, of course, the Rise and Ride studies, we use mandatory monthly injection scheme. If we plot these 12-month needed number of injections of these DME studies against the mean best-corrected visual acuity change, we clearly see a positive correlation and conclude that a higher number of injections is accompanied with a higher positive change in visual acuity. However, these are protocol results of protocol patients. Holkamp and colleagues look at the large national claim database to determine real-world treatment of diabetic macular edema and found that patients receive between 2 or 3 anti-VEGF injections in a 12-month period. That means that in real-world patients with diabetic macular edema, they usually receive fewer intravitreal anti-VEGF injections in clinical practice than in published clinical trials, with consequently less visual acuity improvements. Other retrospective study, the Arginine study, found not such a bad performance with a mean of 7.3 injections in the first year with a visual gain of 8.3 letters. Either Holkamp or Arginine's results, we can agree that real-world patients differ quite a lot from protocol ones. But what is MicroPulse laser, and which is the difference between MicroPulse and continuous wave laser? Continuous wave laser is a traditional laser where we set a specific power and time of action of the laser, and that through all this time, laser energy is delivered continuously with a pair elevation of temperature in the target tissue, even at the lowest levels of energy. During the continuous wave pulse, the temperature rise is extreme, leading to coagulation of the target tissue. It is this effect that provides a visible endpoint seen by the physician as a white lesion. The modality, although clinically effective, has the disadvantage of retinal destruction. Different from continuous wave laser, MicroPulse technology finally controls thermal elevation by chopping a continuous wave beam into an envelope of repetitivity on and off microsecond pulses, allowing tissue to cool down between pulses, and this reduces the thermal buildup. This kind of laser and energy delivery results in greater confinement of photothermal effects and equal or better patient outcomes with no collateral damage. In this kind of treatment, where we do not have thermal elevation, there is no white marks and destruction of the target tissue. This means that after a complete MicroPulse treatment, we will not have any visible mark on the retina. But what this treatment strategy does exactly in terms of biological effect that explain his therapeutical effect? Many studies have shown that MicroPulse stimulates the upregulation of many intracellular biological factors with anti-angiogenic and restorative properties without the tissue damage seen in continuous wave. Between these upregulated molecules, we found PEDF, TSP1 with angiogenic properties and antipermeability properties, and also beta-actin with structural reparative functions. MicroPulse laser not only has shown to be effective in treating clinically significant diabetic macular edema, but also has shown any change in fundus autofluorescence, showing at least not clinical visible damage of the retinal epithelium. Interestingly and unexpected, the retinal sensitivity assessed by microperimetry showed a significant increase in the median central 4 degrees and 12 degrees at the 12-month follow-up in the MicroPulse group compared with the continuous wave treatment. In the clinical evidence, here is a list of some of the studies that have shown the MicroPulse efficacy and safety, many of them through randomized controlled trials. From this list, and in sake of time, I will show you briefly the results of Daniel Lavinsky. Daniel Lavinsky conducted a randomized clinical trial where he compared the results of 3 treatment groups: a modified ETDRS grid with continuous wave laser, a MicroPulse high density, and a MicroPulse low density pattern, and clearly found a greater reduction in OCT measures and greater increase in the number of letter gain with a high density MicroPulse treatment. Let's talk about these high density and low density treatment protocols. In a high density spot treatment with continuous wave laser, each spot has a central area of destroyed retina and a peripheral area of the retina affected by laser but not destroyed, which contribute in part to the therapeutic effect of laser treatments. Of course, a high-density treatment will have greater therapeutical effects, but also greater areas of destroyed retina. What changes in all of these strategies is the proportion of the area destroyed by laser. In the case of MicroPulse laser, each spot of the treatment produces no retinal damage with therapeutical effects. This advantage gives the opportunity to treat complete areas of the retina affected by a macular edema without any harm. So we can use not only the traditional low-density or medium density treatments as the ETDRS or modified ETDRS grids, but new high density treatment protocols to cover the complete area of affected retina. But how we can achieve this kind of high density treatment in micropulse therapy? This question is relevant because, as you remember, this is an invisible treatment. Imagine in this clinical animation, you first recognize the fovea. Then you imagine and visualize your treatment protocol, let's say a modified ETDRS. Then you bring the laser beam to your first shot. But you actually are not seeing any grid because the grid is in your mind. Then you apply the laser, and then you don't see nothing because it's an invisible treatment. And also in real life, the patient is having microsaccades and moving. How are you going to complete a high-density treatment? For overcoming this situation, Aridex has integrated with the laser a scanning laser delivery system that adds the use of multi-spot pattern scanning that can be used either in the MicroPulse setting of the laser for MicroPulse treatment or in the continuous wave setting for panretinal photocoagulation. These patterns, grids, circles, and arcs allow us to treat complete larger areas of retina and increase our reproducibility. This is an animation of what the TXL adds to your protocol. Imagine that you are going to treat this diabetic macular edema patient with a high-density strategy. What do you do first is to identify the boundaries of the macular area you are going to treat. And you do it clinically by FA and by OCT. Then you set your first grid, let's say this square of 7 by 7 points. Then you center your first grid, and what you do is to identify the anatomical limits of your grid and apply the laser. Then, when the 49 points of the grid is complete, you move to the adjacent spot, remembering the anatomical limits, vessels, exudates, etc. After the procedure goes area by area, the complete treatment is finished in a high-density protocol, and a mean high-density protocol of this includes between 600 and 1,200 spots per treatment. Here is a video of a patient treated by this kind of confluent 7 by 7 protocols of MicroPulse laser. Please notice that after the treatment, you cannot see any white mark, as we usually do in continuous wave. To set a difference and a comparison, I will show you a video here with a panretinal continuous wave, traditional panretinal photocoagulation, when you can see how the grid is applied in this pattern, scanning pattern, and obviously, because it's a panretinal photocoagulation with a white lesion mark. Let's see some examples of some patients here. This is a 70-year-old female with proliferative diabetic retinopathy with panretinal photocoagulation and a history of phaco-vitrectomy in the left eye. In January 2013, we found no diabetic macular edema with a visual acuity of 20/30 in the right eye and an atrophic macular with a vision of 2800 vision. In June of that year, she had a metabolic descompensation and came to the office complaining of vision drop to 20/50 and 21,200 respectively. This was the clinical fundus appearance. And here we can see the infrared imaging, the angiographic macular edema, and the OCT appearance. And for the left eye, the same thing, the infrared imaging, the angiographic appearance of the edema, and the OCT with the intraretinal cysts, and the measurements of this atrophic macular edema. That's why is the number of 154 microns, but with an edematous macula. So we decided to treat it with a high-density protocol with only one laser session And 3 months later, this is the clinical appearance of the OCT, where we got a disappearance of the intraretinal fluid in this patient. And also here is a comparison of this with this other infrared imaging. And the left eye has also the same picture. The upper images are the pre-treatment, and the image below is the post-treatment 3 months with an improvement in visual acuity that returns to the baseline pre-edematous status. Here, the best way to compare this benefit of the treatment, in my opinion, is to see this grid, that this square is the comparative or change map in the Heidelberg imaging, where the green and white areas are areas of greater reduction of the edema. This second case is a very interesting case. This is a 70-year-old female, also with diabetes mellitus, and with diabetic retinopathy, treated already with panretinal photocoagulation, and also glaucoma. She used to have multiple injections for diabetic macular edema in the right eye, 5 in 2012 and 6 in 2013, from January through August, with no response, but with elevation of the intraocular pressure. This is the FA and OCT appearance of the right eye in March, with an angiographic macular edema and the presence of some cysts in the OCT. This is the comparisons of both eyes. Since the fluid was not so bad, I suggest her to just observe. However, she went for a second opinion and had a regular focal laser and 3 intravitreal bevacizumab injections with a vision drop. This is a fundus autofluorescence and OCT appearance when she came back with an obvious worsening of the edema, as we can see here in this comparison down in the left bottom color map. The white and the red areas are areas of edema worsening. We decided to treat her with MicroPulse treatment, especially in this case because of the ocular hypertension she had developed. And we use a high-density protocol. We use 600 spots, always with a 5% duty cycle. And 3 months later, she came back again to 2050 with no edema, either clinically or by OCT. And here, the comparison map, again, in the bottom left, the green areas are areas of macular edema reduction. So we can conclude that MicroPulse laser therapy is an effective treatment for diabetic macular edema. It's a safe treatment because it doesn't harm the RPE and doesn't produce any kind of burns in the retina tissue. That the addition of TX cells adds important features of reproducibility and repeatability of the treatment, and that we should consider this treatment also an important competitor and tool to other standard treatments as the traditional anti-VEGF injections. Also, we must remember that different treatment modalities as this one, either as monotherapy or in combination with anti-VEGF agents, could be the first-line therapy in real-world patients that are outside of the protocol patients that we usually consider the traditional results of the studies. Thank you very much.
Thank you, Hans. That was fantastic. That's a great review of the science behind MicroPulse. I have to admit, I would walk by the Iridex booth for years before I really got that we were doing something different. It takes a while to think about doing something differently than the way you've been taught. But I'm Ahad Mahuchi. I'm from the United States, in Tampa, Florida, and I am a type 1 diabetic since just before starting medical school, so I have a special interest in the fovea and my fovea. So why I chose MicroPulse and how I've incorporated it in my practice, I'm going to talk a little bit about maybe a little bit less about the science, but I had been reading about the fovea-friendly and no tissue damage focals. And so I thought, well, if you can do something the same way, get the same effect without the side effects, that's got to be a better way to do it. I had started to see the efficacy through now lots of trial data that showed that with practical experience, this was a durable treatment that actually worked. But more importantly, and this is just not a laser with a better foot pedal or a joystick that's better. You can actually do things that you can't do with other lasers. You can treat through the center of the vision, through the center of the fovea, which is an amazing thing. And you can treat diseases that you couldn't treat before. So this is a really very different product. So that meant that I could treat more patients than I could with traditional laser, and the laser wasn't a one-trick pony. It didn't do just one thing. I could use it as a continuous wave machine, but I could also use it as a MicroPulse machine, and I could also do glaucoma with it. So one machine does lots of different things for one price. So we're going to talk about diabetes. The MicroPulse offers an ability to treat early or late in the treatment program, and admittedly, I would do things a traditional way and then use this later if things didn't work. I, like Hans, I think have moved to doing this as primary treatment. A lot of times, obviously, you can't laser the center of the vision. You can't laser the fovea with traditional continuous wave. So patients that were unresponsive to anti-VEGF treatments were a candidate for this. Patients with really good vision that you didn't want to risk with continuous laser giving them a watermark in their vision or a microscotoma, this was a better way. Or when anti-VEGF wasn't a treatment, like in pregnancy, stroke, or if they were getting problems with glaucoma and repeated injections. So it also helped with clinic not having to see the same patients over and over and over again, just doing injections. So it allowed me to get on with my life and them allowed to get on with their life. So the three big advantages I'd have to say are that you're able to treat patients with better vision, you're able to treat edema in the center of the vision or closer to the fovea than you can with traditional laser, and you don't get the little microscotome or the visual field loss. So these are the three big differences in MicroPulse. It's just a different laser, a different treatment than what you're doing with continuous wave. So this is one of my first cases. This is a diabetic, 70-year-old, non-insulin dependent diabetic with terrible long-term control of 8 to 9. She works as a legal secretary for a really prominent lawyer in my community. And her computer vision is worse, and she tells me that her reading speed, she just cannot read as fast as she could, although she still has 20/25 vision. And you can see the edema in the center of the fovea. I have coached her on doing everything she can to lower her hemoglobin A1C. She doesn't smoke. We've tried lutein. We've tried every kind of natural thing that we can do. And here's the swelling. And then we do MicroPulse right through the fovea. And I don't treat as big of an area all the time as you do, Hans. Sometimes if it's just limited to the center, you do treat confluently and you treat a bigger area than you see, but I haven't done the 1,000 spot, 600 spot treatment. I have done around 200 to 2 to 400 in the center of the vision. So I treat a bigger area than what you're seeing. And then I also tell them that you're not gonna really see anything until about month 4. So I use 100 micron spot size. What I originally do is just do a test spot somewhere and to make sure that, to find out what the minimum spot energy you could use, spot size, spot energy to create a burn, and you go down 1, and there's kind of a formula for figuring out what the MicroPulse should be. And I usually only stay at 5%, don't go to 10%. There's pretty good science that shows that you get burns, even little ones at 10%. And you can pre-treat with Avastin if you want to get them better sooner, but you don't have to. And in the 23 months since the laser, her vision has improved to 20/20. She's happy. She's subjectively improved without any scotoma. And her hemoglobin A1C is just still horrible, but that's what she looks like now. And that's just last month. So it's 23 months later. So here we go. That was 4 months. And then now you see what she looks like now. So it's a pretty fantastic result, and this is pretty typical. You just have to be a little patient with the results. You're going to get it takes longer to take effect, but you get a very durable effect. She's had no intravitreal Avastin or injection of any kind since that time. So does it work for, it works for one-time therapy, but it also seems to work for other chronic diseases that might need more injections. You typically would think like vein occlusion and some diabetic macular edema needs injections over and over. Well, as the KISH studies show, that most people don't actually get the injections the way that they're labeled, and that's not a surprise. People live in the real world. They can't afford co-pays. They don't want to come to the doctor all the time, and we're really filling our clinics with people who are sometimes in some clinics you'll see robotic injections over and over and over again. But the problem is, as most of you have seen probably, after 3 or 4 years, some people get resistance, but a lot of people get atrophy. There's a nice side of VEGF treatment, but there's an ugly side too. You can get something like geographic atrophy. So here's a patient that I did early on, an 84-year-old with terrible diabetic controls, diabetic macular edema, and branch retinal vein occlusions in both eyes. The edema has returned after years of Avastin. I believe this one had 31 injections of Avastin. And I had started, after about a year of doing MicroPulse, I did her treatment. And I did some injection 3 months before to bring the edema down. And then you'll see what happens here around December of 2014, and that's when I do the laser. And then we'll see in one eye, I'm sorry, if I go backwards, this is actually, I did the injection, and then 4 months later, this is what the edema looks like with no Avastin, and believe it or not, no Avastin, Eylea, or anything in the year since. And it's been getting better over time despite not doing anything. So here's the other eye. It looks horrific. The vision's still not great in this eye, but the edema's gone, and they have a time to enjoy themselves doing other things but coming to the doctor, and their vision is actually improving over time. So it's common to see that treat and extend works, but works less well with time. A lot of times you'll fall back on ever shortening intervals. You can get them out maybe to 12 weeks, and then it starts going back to 10, 8, 6. You'll have to use your mind a little bit to mix drugs using Eylea or Avastin or Lucentis. It gets more complex, and sometimes they have other things that keep them from getting the injections. So now you just have another weapon for a two-front war. A lot of things in politics, war, and medicine, cancer. The more weapons you have, the less chance the opponent has to survive it, in this case, diabetic macular edema. So it treats diabetic macular edema like the other lasers, but you can treat the center of the vision, which is different. You can treat macular edema from vein occlusions, but you can treat the center of the vision, which you can't do with other lasers. You can treat central serous retinopathy in ways that you can't with other lasers. You can treat it right in the center of the vision. I've had success with pseudophakic cystoid macular edema for folks who didn't get better with steroids and non-steroidals or intravitreal injections of steroids and everything else. And then I think we're starting to see people from around the world, and I certainly have tried this for edema for wet AMD. And I think this is a game changer, because if you can reduce the number of injections, so even if you don't eliminate it, you're extending the life of these other medicines that you can use. And it's really amazing. Almost a third of the time it seems you can eliminate the injection. A third of the time you cut it into only 2 or 3 injections without losing a year. And then other times you're just doubling usually the frequency of injection that what they used to have. So, and that's kind of my summary of, in chronic diseases, that seems to be what it is. For not diabetes. In diabetes, it seems to work as a one-time shot for most people. So remember, you can use the laser for more than one treatment. Your goal may just be to stabilize the OCT, not perfect it. So you can reduce but not eliminate anti-VEGF treatments sometimes, but often you can. And you can achieve a stable vision in OCT without the cost and atrophy associated with repeat injections. And you've got a financial situation that's better for everybody, you, the patient, the insurer. Certainly the drug company's not the beneficiary of it, but I think they're doing pretty well. One of the other advantages is this is, you don't give up the continuous wave if you want to cut sutures after a trabeculectomy or do traditional laser for retinal tears. It can be used for traditional, for non-traditional PRP. A MicroPulse PRP can do the same thing without the field loss of damaging the ganglion cell layer. You can use it for trabeculoplasty in either MicroPulse or continuous wave mode. I do mainly MicroPulse. It works the same as ALT or SLT, but without the pressure spikes. You can use this laser to treat more conditions and more people than you can with traditional laser, and you're saving people money. A great example from my clinic is I was expending about $40,000 a month on Avastin, Eylea, Lucentis, and this has dropped, and it was growing by about 30% per year. In the last 2 years, this has dropped to $13,000 per month, which is a big game changer for me. So the reasons that patients can drop injections are cost, frustration, and tachyphylaxis, and the side effects of atrophy. Remember, atrophy from repeat injections can be just as bad as the original disease. This, whether it's from vein occlusion, diabetes, or macular degeneration, is not good. So this gives you a way of avoiding that. If you don't altogether get rid of the injections, you can at least delay the time that geographic or that kind of atrophy occurs. And MicroPulse isn't exclusive of other treatments. You can still do the other treatments. So in conclusion, it's typically, there's no visible tissue change, as we saw in the movie that Hans did. The response is typically slower than pharmacotherapy, but it's more durable. Literature and the real-world experience supports safety and efficacy, and it's a better experience for the patients than repeat injections. So it can be used as first-line treatment or an adjunct to current another treatment, and it's an option to pharma for many other diseases as well as glaucoma. So someone had asked I speak a little bit about MicroPulse for trabeculoplasty, and here's some of the parameters. You just use a 300 micron spot size with 300 milliseconds. It's very similar to SLT, except you're using a 15% duty cycle, and you're using a laser that can do just more than SLT. You treat 360 degrees, you hardly see anything. Its advantage over ALT is that you can treat patients who don't have pigment. It works if you don't, whether you have or don't have pigment in the trabecular meshwork. Advantage over SLT is there's no pressure spikes, and 85% of patients get a response in 6 to 8 weeks. And you can retreat later with the same effect. So conclusions, less costly than injections. It saves money for everybody. There are less side effects. We delay atrophy and the microscotoma of traditional laser. And once you kind of get your head around how MicroPulse works and how it's different from traditional laser, you really see a world of opportunity open ahead of you. It's so different in the way that it works. I have to admit, it takes a while to get your head around that. So thank you very much. If you've got any questions for either Hans or myself, please submit them, and we'll be happy to take them, or we'll take them from the floor too.
Thank you, Had. Great presentation, and also with all this experience you have in the treatment of this patient, it's very valuable, your opinion, in many of the questions that the audience is sending to us. So at this point, we are going to start trying to respond some of the questions here. And some of them are in the same area. First is if MicroPulse treatment is repeatable, and which is the interval of how do you repeat this, and when do you start to treat this kind of patients? When do you decide to retreat them? How do you initiate with anti-VEGF treatments or combined therapy, or wait to see if the anti-VEGF agent does not work?
I'll use the same indications that I use for regular laser, the vision or the subjective complaint of the patient along with the data that shows the edema is the cause of the problem. In terms of whether it's repeatable, it takes a while to get the effect. I think it's less so in diabetes than it is in vein occlusion and other diseases, but I'll usually wait at least 4 months because you're starting to see the treatment. Sometimes it doesn't really, you don't see anything until month 3 or 4, and then it starts to kick in and you see the improvement over time. So if they're getting better, I probably won't treat. If they are getting better, but they want some more, 6 months later, I'll do another treatment.
This is an interesting question because we have to remember two things. The diabetic macular edema patients are patients that have to be followed and treated in a very specific terms, very personalized, the same as for example, AMD patients. Each patient, each eye has its own rhythm of how demands treatment. Because it's not the same to treat a patient with diabetic macular edema that is just initially or is a complete...
Hemoglobin A1C of 12 for 3 years. Yeah,
for example, like that. Or if it's a macular edema that involves the center of the fovea or it's outside, threatening the center of the fovea, you have different times to wait or not to treat these patients. For example, if many of the questions here is how fast you see the response of the treatment. What is your experience on that? How fast do you see that the fluid is gone?
I don't see it usually in the first month. Sometime about 20–30% you'll start to see it at month 2. I quit checking actually because now I just give them the whole 3 or 4 months now. But if you follow them closely, you'll see there are various responses, but it's just easier, it seems like. It's going to work in about 4 months, 80% of the time or more. So I don't worry about it too much.
Yeah, that's the thing. You can't expect to have the dramatic effect of, for example, of steroids with this kind of treatment or anti-VEGF treatments. They act very quick, but the problem is that they demand a lot of treatment, of drug. The advantage of combining this kind of treatment is that the period where you need, again, anti-VEGF treatment comes longer, or you stop needing them anymore. That's one of the advantages. And how do you combine also with focal traditional thermal laser, or you don't use any more?
Not anymore.
Not anymore.
Not anymore. Not anymore.
Excellent. That is a very important thing. And another thing that we must think about is that many of the treatments of the studies where anti-VEGF treatment are based in clinical trials, all the arms of the laser treatment, the traditional laser treatment, are arms that are not well controlled. For example, the DRCR-NET study about diabetic macular edema didn't have, the way they choose the laser parameters was on a survey, not in scientific data. And if you review all the studies that compare anti-VEGF treatment with lasers, the laser arm is unobserved and uncontrolled as the other treatments.
There's a question, a real simple one I'll answer. Do you target microaneurysms? The answer is no. That's not the way the laser works. It doesn't create a burn, so it can't seal a microaneurysm unless you put it on continuous wave. So you just paint the area around it, and the science behind that is that the retina heals itself with some stimulation from the laser. Another question I saw was, do you use a constant power, or do you change from patient to patient? This seems to vary. I think you use a constant one, right?
I start with the recommendations that you said. The initial recommendations were to make an external fovea area shot to see a barely visible burn and then modify the treatment according to that. But later on, and talking with some other colleagues, What I usually do is, on all the patients, I use 400 milliwatts of power, 200 milliseconds of time, and I always, this is very important, always to use 5% of duty cycle, because if you increase the duty cycle, you can have some very subtle marks, especially in infrared imaging or in in fluorescence, autofluorescence, and fundus autofluorescence. And I always use the pattern, the TXL pattern. That's why probably the protocols you saw are a little bit different, because I treat the complete area that is edematous either by FA or by OCT.
And I'm different. I still do the test spot. If you do the math, I think everyone who does this, when you're still a little bit skeptical, you'll do the math and you'll see your safety margin, even if you're doing your test spot 20 milliwatts hotter than what creates a spot, or 20 less. You have a wide safety margin. It's incredible how much you have. So, and I think, I remember somewhere, you can really hit the same spot 2 or 3 times, not that you'd want to, and still nothing will happen in burn-wise. So I didn't get the Texel initially. It hand-painted, so if you're going to do that, just remember to be confluent. But it works in either case. I guess as we learn more, we'll find out whether a subtle difference in power makes any difference or not. If you kind of understand the science, it seems like it wouldn't. It seems like
Here are 2 questions about if you can see a tissue reaction, how do you know you have done anything? And at the beginning is, you know, when we used to see the one we used to see laser spots, and then you treat and you see nothing. You don't know if you are doing something. So at the beginning is a little bit of I don't know how to say it.
I had the same. For 2 years, I wondered in my mind, well, is this a sham treatment? Am I doing anything? But you see the difference in the edema. You have to be doing something, even if you're. So that's the incredible part. But then the science part, as you showed, there is good basic science that shows that these growth factors and hormones, microhormones in the retina environment are changed. So you know you're doing something, you're just not burning. So that's how you know. There's no arguing that the edema goes away. This is pretty impressive.
Yeah, a good term for this is probably photostimulation.
Yes.
of the retina and of the RPE. And that's basically what you are doing. It's like doing a resuscitation of yield retinal of epithelium damage. Another thing, for example, when in a pathology where you see a very fast response, and I found incredibly useful, and it's my first kind of treatment, is in central serous chorioretinopathy. It works extremely, extremely well, either for acute cases that we know that is going to be self-limited in enormous percentage of times, but in chronic and in multifocal central serous works excellent. In 1 month, if you do an OCT of comparisons, you can see how the fluid is gone, and the patient, this idea of waiting 1 or 3 months in central serous in the past was because there was not real effective treatment. If you use thermal laser, you have the problem of probably doing a CMV. If you use, for example, PDT, that also works very well, the problem is the cost. Here you don't have both, and it's a very good pathology where you can use.
And for central serous, I will give them the chance to get better. If I'll tell them to, you know, studies show that there's a good chunk of you that might get better. So just to not confuse the issue, I'll let them try to get better for 3 or 4 months, and if they don't, then do the laser, and it seems to be fine. There's and it gets better where it didn't get better with just time alone. There was a question about can you use MicroPulse on patients that have already received traditional laser, and absolutely, you're again affecting a different treatment. There's I've done this many times, especially early on before I used it as a primary treatment. I'm sure you have too. Right?
Yes, actually the second case I present, or the first case I presented to you, she came with a worsening of the edema after a focal thermal photocoagulation, and you can use it and you can repeat it. My particularly time to decide if I will retreat the patient or not is between 3 and 4 months. If we remember in the past when you use the regular ETDRS grid, the idea at that time was to wait until 6 months to see the resolution of the edema and to decide a new treatment or not. In this kind of treatment where you do not make any harm to the retina, you can use it more often.
Another question was, what about diseases like CRVO? Really anything that you've got macular edema, it seems to be successful. Even radiation retinopathy, I've seen success with that. And how far the thickness do you start? I'm not sure what that, but if you're saying, if you want to reduce the thickness before treatment, I've done, if it's very thick, it just seems to make sense to try some Avastin or something like that to get it thinner before doing the laser. And it also allows them to see the benefit, and if they're impatient. But if it's not a lot of gross edema everywhere, I won't do the Avastin beforehand. I'll just treat with, if it's just like one spot of edema right in the center.
I think here it's very important to remember the idea of treatment macular edema, that is to prevent visual loss. That's the idea of the treatment of macular edema. And in many of patients, of course, the aim and the will is to gain, again, visual acuity. In this idea, if you have the patient with a mild or a moderate macular edema that is not very in the center of the fovea, they are great candidates to start with MicroPulse therapy because they will have time to see the benefit of the treatment. They do not need an initial fast recovery of the vision in the center, and it's going to be more effective in terms of the economical thing. This situation of the economical status varies from countries to countries, from health system to health system. But of course, it's an issue that we all have to have in mind. And probably we haven't made it clear that the same machine, the same laser, can be working in both modalities. Continuous wave for example, traditional panretinal photocoagulation, or to change it to the MicroPulse treatment.
This is a good question. In central serous, what are you treating? The entire area of the detachment, or a bigger area? Or what?
It's a good idea. It's a good question. What I do, I don't know you had, but what I do is I only treat the spot that is hyperfluorescent. If it's a very chronic case where the retinal epithelium is already damaged, I assume that probably the epithelial choroid pump will not be working as healthy as we suppose it should. So in those cases, with chronic disease where the retinal epithelium is damaged, I treat the complete area of fluid. If it's an acute case that is more than 1 month, I only treat the fluorescent spot.
And now they know the genetics of the central serous and wet AMD are connected, and you can't not notice how many 40-year-olds in their old charts had central serous that now have wet AMD, and develop even in the other eye. I think you could argue either way. There's a great question about how to cut nylon suture without burning it, and I do it the same way. I do it in continuous wave. I just set a very short time interval, like 0.08 second, and then I have like 700 milliwatts in a very small spot, and usually it pops the stitch without burning the conj. And do you need good pigmentation for MLT? This was a huge selling point for me because I didn't want to buy a SLT that just did SLT. So here I do all this retina stuff, and I have the advantage over ALT of just being able to, I can treat, I don't need any pigmentation to answer the question shortly, but you don't need any pigmentation. So unlike ALT, you can double or triple the number of patients you can treat with this. And unlike SLT, it's not just a box that sits there just doing laser. So that's an advantage. And here's a question. I have an Iridex laser but no tech cell. So what do you suggest doing for diabetic macular edema and central serous? I paint it just using the test spot protocol that's on the website, and I'll just go outside the area. I'll usually go outside the arcades even, or just inside the arcades and do my test spots. And I think I was probably I was more sloppy than I should have been early on in duplicating the tech cell. You really do have to paint confluent spots to get the best results. And you'll cut down on the number of retreatments if you either get a tech cell or you're super anal about how you put these spots in. Do you have anything to add?
Yes, well, at the beginning when we got first the laser, we didn't have the TXL. And at that time, I had really hard time in doing the treatment, because as I tried to example it in the animation, the patient is moving. You said, I make the shot here, and then you have to remember where you were. But when with the pattern, what you have to remember are big areas of retina. So it's very easy. And one of the bias I have in my practice in the hospital with teaching with the fellows and in the research area is reproducibility and repeatability. And by far, my treatments with the TXLs are much more reproducible, because all the variability comes to very few points. So I strongly encourage everyone that has not used the TXL to use the TXL, because at least in my hands, my results change a lot with that.
I think maybe I thought initially, and to some degree I think this, the picture of the diabetic edema you saw there was terrible. It's everywhere. But a lot of people just have focal disease. And so I don't just treat the edematous area, but often I will just do 200 spots if it's just macular, because I think either way, treating the fovea is what gives you the better vision. The other stuff probably helps long term, yeah. But getting the center clear is going to make the patient happier.
Yeah, an example of that the TXL is not necessary and mandatory is AHAT's results. All the specialists that have used this treatment without the pattern, and all the results are without the TXL. So you can use it with or without, but it's much easier if you use it with the TXL. Absolutely. It's much more easier, yeah. And of course, one thing you have to talk with the patient, and at least I had that concern, is that you have to tell the patient that he or she will not have anything in the retina. Because if she goes or he goes with another physician and says, because I got laser in my eyes, and he saw inside, and you don't have nothing. Yeah. The physician didn't treat you nothing. But when you explain that it's an invisible treatment, that is a treatment that is going to stimulate their own tissue to recover, is very, very good accepted by the patient.
Absolutely, and honestly, I've never had a patient leave to question it, because usually it really does work.
Yeah.
So we've got a few more questions. I remember actually practical things. It works with, you can get a Zeiss adapter or a Hogstrite adapter. It works with a number of different slit lamp systems. Should we use 5% or 10% or 15% MicroPulse in CRS? 5 is what I recommend. But
yeah, I have, at the beginning, I didn't follow the advice of the experts in this field, and I used 10% or 15%, and do not use it in diabetic macular edema or central serous. I think 15% or 10% would be better, and is the parameter to use, for example, for glaucoma. But for laser, for retina, if you do 10% or 15%, you will have either in infrared imaging or in fundus autofluorescence some minor marks that in the OCT you can see something happening in the RPE. So I think 5% is the rule.
Thanks everybody for coming. There's one more question I'll do, but we probably have to clear the room after this. But thanks, Iridex, thank you all for coming. But in the case of very bad diabetic retinopathy with DME, should you first do continuous wave laser of the periphery and then treat the macula or the fovea with MicroPulse? And I don't think so, but should you do continuous wavelength, first? I don't see that as necessary.
Well, if you have the macular edema, you have to treat it with choice, MicroPulse or anti-VEGF treatments. But if you have larger areas of ischemia, these areas of peripheral ischemia are producing VEGF. So now the idea of doing panretinal photocoagulation in these peripheral areas will diminish in the long term the amount
I was thinking just fovea, but that's a good point.
Yeah.
That's good. And then for test burns, if you just want to come to me afterwards, or whoever wrote asking about the test burns and whether they vary with the amount of edema, no, but I can explain that to you right up here if you want to meet me.
Thank you very much, and thank you, Iridex, for that.
Thank you.